either toxicity or of hypovitaminosis. So this is one of those instances where there's not a lot to do other than to learn what the classic signs and symptoms are of too much vitamin K or too little vitamin D. Unfortunately, this is one of those scenarios where really you just kind of have to memorize, unfortunately, and the memory jogs will help you do that, but we'll try to tie it in so it makes sense, but some of it you just have to hang your hat on and go, okay, I know that, vitamin C does this if you don't have enough of it. So these are the objectives. You can read those on your own on the card if you'd like, but basically we're going to talk about a few specific vitamins. So we're going to look at the toxicities and also deficiencies in vitamin A, vitamin B1, riboflavin B2, niacin, vitamin B6, vitamin C, and D. We'll talk about what they do normally, and then what if we don't have enough of them, and what if we have too much of it. And those are the only ones we're going to hit that are listed there on the topics. So micronutrients, what do? They're vitamin and minerals. Very small quantity requirement in our body for homeostasis, but they do play a huge role, an essential role in metabolism, right? So a lot of vitamins are going to function as a coenzyme in reactions in our bodies, and then they'll also function as prosthetic groups. What does that mean? They permanently bind to an enzyme to help that enzyme undergo some type of reaction, like usually a catalytic reaction. So much like a coenzyme, except that they're permanently attached. They're biochemical substrates. They can be hormone signaling molecules. And because the vitamins are essential in many of the metabolic processes and pathways in our bodies, the deficiencies a lot of times, as you'll see when we talk about too much, too little, it's going to be multi-organ or multi-system. Usually it's just not too little of this or too much of this causes this one thing. Because it's in, usually all the vitamins are in more than one metabolic pathway, it's going to present itself if you have too much or too little in a multi-organ or multi-system kind of way. So the body maintains our nutrients in pretty much a tight physiological window, meaning from here to here is good, above this level is bad, below this level is bad. Just a tight window of what our bodies need for our normal function and homeostasis. So if you have too much or too little, then we start to have issues. Several factors are going to influence what our body needs. Each person's going to be a little bit different, right? So what our diet is going to be a factor. How old we are is going to be a factor. If our patient has any type of metabolic disorders that are genetic linked, then that's going to affect the nutrients or vitamin use in that individual's body. What medications we're on, as you've seen in pharm, like medications can heavily influence loss of things when you start looking at things like diuretics and the different actions that it causes on the kidney that cause us to excrete certain vitamins and minerals. Lifestyle factors, huge in homeostasis of micronutrients. Comorbid diseases, and obviously pretty much anything that affects normal function of our body. Pregnancy also affects how many nutrients we need and in what levels. RDA is the U.S. Institute of Medicine and National Academy's Food and Nutrition Board. They set, hey, daily intake is good here, up to here, bad if over this, not good if below this certain level. That's really all you need to know is that our daily intakes are set, right? We have this board that can tell us what's adequate as a general rule. So you'll see it expressed as maximum daily intake or minimum daily intake. So minimum, obviously, the lowest amount we need for normal function and to sustain our nutritional needs, and then maximum, anything above that, we think, okay, this is going to start leading to toxicity. So big concept here is solubility, fat solubility. So fat soluble or water soluble. Fat soluble are A, D, E, and K. Why is that important? Is because fat solubles are stored in our body fat. So if we store things in our system, they're much more prone to giving us problems if we have too much of it, because we're storing too much in our system. Since a lot of vitamins are stored in excess in fat, the fat solubles give us more of a problem with too much intake of those vitamins. So greater risk for toxicity. Water soluble, which are B and D vitamins, B and C vitamins, they're not stored extensively, especially not in the fat, like the fat soluble ones are. So deficiencies are more of an issue for B and C vitamins, as a rule. There's a couple of exceptions we'll talk about, but generally, more of a problem with fat solubles, A, D, E, and K with toxicity, and then B and C is more of an issue if you don't have enough. And then a couple of terms you need to be familiar with there: hypervitaminosis and hypovitaminasis, like we discussed at the beginning of the lecture. And then there's a couple of malabsorption syndromes that will affect the storage of the fat-soluble vitamins listed for you, such as, there's many others, but inflammatory bowel disease, which we'll talk about in Block 2, and cystic fibrosis, which you've probably already talked about in home. So vitamin A is what we're going to start with. They're known as retinoids. They have biological activity similar to retinol. So what does retinol do? It stimulates collagen production in our skin, maintains firmness, elasticity, and such. So basically, retinol supports skin structure. So one of the most important things you need to be aware of with vitamin A is vision. Vitamin A is a portion of, it's a component of rhodopsin, which is light-sensitive pigment in our eyes, in our retinoid, or our retinal rod cells. So if you have vitamin A deficiency, commonly affects our night vision. So you need to know that association with vitamin A deficiency. There's an RDA there, roughly be aware of them. I'm not going to ask you any questions about any of the vitamins, what the RDAs are. You're more than likely going to see signs and symptoms of some classic deficiencies or toxicities, and you have to choose which vitamin. Or if we give you a vitamin and say it's too little, not by number, just say we don't have enough of this, or it's in a hypo intake state, what would be the signs and symptoms that you'd see? So in the U.S., vitamin A deficiency is pretty rare, but it is still common to have a deficiency in developing countries. It is an issue because it's fat soluble, fat malabsorption syndromes like IBD, as I mentioned, cystic fibrosis, and chronic pancreatitis. You can still see that in our population in the U.S. with any of those malabsorption issues and vitamin A. So night blindness is usually the earliest thing you're going to find with deficiency. And there's a name for it there, nyctalopia. But as deficiency gets worse, then we develop more symptoms like xerophthalmia. That's basically just dryness of the conjunctiva and cornea. So first night blindness, then some dryness of the cornea and conjunctiva. And then you get these characteristic findings in severe disease called Beteau spots. And there's a picture on the next slide. But basically, it's white, foamy, keratinized patches on the conjunctiva. So not to be confused with foamy macrophages, right? You can recall that from the disease process we discussed last week. If it continues and you get more severe vitamin A deficiency, it can lead to keratomalacia. So that's a degeneration and ulceration of the cornea, and that can cause permanent blindness. So on the slide, basically you're seeing from mild or moderate deficiency to worsening, and you can see the situation for your eyes are deteriorating based on how bad or how prolonged the deficiency of vitamin A is. There's a picture of the Beteau spot, light, foamy, focal area keratinization on the conjunctiva. And vitamin A deficiency, if you see these, you definitely think vitamin A deficiency. Very characteristic. and it's an advanced sign. So if you see it, your patient is very low in vitamin A. Vitamin A deficiency, often clinical, based on the signs and symptoms I just discussed. There is a lab we can draw serum retinol. Less than 20 micrograms per deciliter is going to suggest deficiency. And then the treatment is going to depend on severity. You got the two treatment options there. If it's early, we don't have those spots on our eyes yet, we just have some early night blindness, then your patient can get like 30,000 international units by mouth daily once a week. If it gets more advanced, then we're bumping up to 20,000 international units per kid orally for at least 5 days. But just know the treatment is we're giving vitamin A, and we're giving it depending on where our patient falls on that categorization of symptoms, or we can draw the retinol. Toxicity, moving from deficiency, now we got too much of a good thing, right? If you have large amounts, too much, usually this is supplements. It's going to be a patient taking too much in. Acute differs from chronic. So acute vitamin A toxicity, nausea, vomiting, lethargy, fatigue, tiredness, right? Headache, papilledema, swelling of the optic disc, that's papilledema due to increased intracranial pressure. You can get intracranial hypertension and skin exfoliation. So a lot of our symptoms from acute vitamin A toxicity, it sounds like a neuro thing, right? It kind of sounds like pseudotumor cerebri, but basically it mimics those signs of CSF building up. But there is no tumor, there's no mass, right? In pseudotumor cerebri, and there's no tumor and mass giving you these neurological symptoms of vitamin A toxicity. You've got an acute, elevated amount of vitamin A, so you get the nausea, vomiting, lethargy, headache, papilledema, intracranial hypertension, and skin exfoliation. I would know those. But also know the chronic symptoms. So if you've got chronic vitamin A toxicity, usually this is going to be like more than 50,000 international units a day for months. Symptoms can include ataxia. What's ataxia? That uncoordinated muscle movement. Folks have problems with their upper and lower extremities. They can't walk very well. Loss of balance. Hair loss. Alopecia is hair loss. Dermatitis, so it's an inflammation of the skin. You can get some liver toxicity, bone pain, muscle pain, visual changes. Vitamin A, we talked about vision already with deficiency, but in toxicity, we get some visual changes as well. Because vitamin A is fat soluble, obviously if we start getting 50,000 units a day for months, then it's going to be multi-system. You see that by the chronic symptoms mentioned there. So definitely know the vitamin A deficiency and toxicity signs and symptoms. Carotenemia. Carotenemia, yellow tinge, orangish tinge of the skin. But your characteristic factor to separate that from jaundice is that the sclera of the eyes don't change color. So with carotenemia, you get that change of the palms, yellow, orangish, but your sclera of your eyes remain white. Particularly with carotenemia, you can get yellowing of the palms and the soles. So that's your differentiating factor between jaundice and the sclera. It's benign, often seen in infants who consume large amounts of pureed vegetables. Don't confuse it with jaundice. So it's from beta carotene, but like I said, we see this in kiddos, infants, sometimes from all the pureed vegetables. If the sclera is not discolored, then we don't have to worry about this being a liver origin. So we're moving on to thiamine, B1. So it's thiamine B1 plays a huge role in carbohydrate metabolism. So it's used in the conversion of pyruvate to acetyl-CoA, so it's energy production. Also, thiamine plays a huge role in nerve impulse transmission. So its roles are going to help you determine these signs and symptoms of too little or too much. So I'm probably not going to ask you a specific question on its normal role in normal homeostasis, but understanding what it does can help you to differentiate and pull it out of the list when we say a patient presents with A, B, C, and D. You can say, oh, okay, I know what vitamin plays a role in nerve impulse transmission, so if you have some nerve impulse transmission changes, it can possibly lead you down the right path. So deficiency, developed countries, this is alcohol, chronic alcohol use. B1 thiamine deficiency, chronic alcohol use. Because alcohol interferes with thiamine absorption and metabolism. Other huge cause are in the world is any population that eats a diet consisted primarily of polished rice. It was polished rice. Right? They get rid of the husk, the bran, the germ on rice, it's just white rice. So what's happening when you get rid of the husk, the bran, and the germ, you're getting rid of the B1, of the thiamine. So in populations that eat only polished white rice, you can see a lot of thiamine deficiency. Two major symptoms, thiamine deficiency, B1 deficiency, beriberi. There's two types of beriberi that are up there on your slide. Dry is affecting the nervous system, and we talked about what B1 does in normal homeostasis. So now if we start to have deficiency, well, it's going to affect nerve impulses. So dry beriberi is nervous system, symmetrical peripheral neuropathy. So into the extremities, both sides, problem with the nerves. Sensory and motor impairments, mainly in the distal extremities, limb pain, paresthesia, and loss of those deep tendon reflexes. Second type of beriberi is wet beriberi. Now we're looking at cardiovascular symptoms. So at the cardiovascular system, right? Significant peripheral vasodilation, tachycardia, high output heart failure, cardiomegaly, pulmonary edema, and peripheral edema. So that's why we call it wet beriberi, right? Fluid building up. So know the difference between dry and wet, the two different types of beriberi from vitamin B1 deficiency. If it continues, it worsens, then we move into yet another thiamine deficiency called Wernicke-Korsakoff. So now we're talking encephalopathy for the Wernicke. Profound disorientation, confusion, ocular motor dysfunction, nystagmus, right? Uncontrolled eye movement. You can also have some paralysis of the muscles that control the eye. So you start to get the inability to control eye movements. With paralysis, ophthalmoplegia is a paralysis of those muscles. Once again, some ataxia. If Wernicke's is left untreated, it goes to Korsakoff. And the signs are there for that late manifestation of WE, of Wernicke-Korsakoff, or Wernicke encephalopathy. Now we're in the second half of it, late manifestation. The Korsakoff is amnesia, confabulation, and impaired learning. So changes in brain function, right? What is confabulation? Anybody? Loud?
Fake memories.
Yeah, you're just making stuff up, right? You're just saying things that aren't true. So for the visual learners, this is a good layout of the thiamine deficiency, the beriberi on the top, the dry, moving down to the bottom left. Now we're talking about the wet, and then over on the bottom right, now we got the Wernicke's. We start having those neurological changes in the brain specifically. So I would know those, the beriberi, wet and dry, signs and symptoms, and then Wernicke encephalopathy, moving into Korsakoff with thiamine deficiency. And here's the slide pulled out of just the Wernicke-Korsakoff for the visual learners, right? So we see the Wernicke's encephalopathy, that ophthalmoplegia, weakness of paralysis of eye muscles, ataxia or unsteady gait, and weakness, uncontrolled movement. And then we move down into the changes in the mental state, confusion, apathy, difficulty concentrating, and if this is left untreated, it can actually cause coma and death. So we talked deficiency, now we're talking toxicity. Toxicity for B1. Unlike fat-soluble vitamins, thiamin's water-soluble, so it doesn't matter how much you take, it goes out with the toilet water. You're going to excrete it. So no toxicity for B1. Lots of bad stuff for deficiency. B2, riboflavin, is part of a group of compounds known as flavins, the enzyme flavin, so that makes it easy. It acts as a coenzyme for oxidation reduction reactions. Essential for cellular energy production. Basically, all metabolic processes in our body, right? So, because riboflavin participates in multiple enzymatic pathways, a lot of times with deficiency, you're going to think mucocutaneous symptoms. And we're going to get into those. Because there's rapid turnover of those mucocutaneous areas, that's why when we start to see deficiencies in riboflavin, you're going to see changes at the mucocutaneous systems because of the rapid turnover of those systems. So B2 deficiency, malabsorption, anorexia, and others, it's usually occurring in conjunction with other deficiencies. It's usually B2 deficiency, not in isolation. Causes are malabsorption syndrome, chronic illnesses, anorexia, poor nutritional intake. Generally mild, common manifestations, like I said, mucocutaneous changes, so cheilitis, so inflammation of the lips, angular stomitis, that what's shown in the picture there, the corner, the angles of the mouth. Atrophic glossitis, there's the tongue, it's inflamed. Seborrheic dermatitis, so inflammation of the skin, usually like a dry scaly rash. Because the skin and the cutaneous system around the mouth and tongue rapidly turn over, that's why you see the changes there around the mouth and the tongue with a B2 deficiency. With toxicity, riboflavin toxicity, same thing as thiamine, doesn't exist really. Not absorbed, limited water solubility. So we worry about the deficiency with B2 riboflavin, not the toxicity. Niacin, vitamin B3. So there's two forms of it, nicotinic acid and nicotinamide. And basically it's a critical component of NAD and NADP. Coenzymes for oxidative reduction reactions again. Interesting though, we can produce or synthesize niacin in our bodies from amino acid tryptophan. You need to know the deficiency of niacin is pellagra, and what that means, the 4 Ds of pellagra. Dermatitis, diarrhea, dementia, and death. 4 Ds of pellagra, vitamin 3 deficiency. Dermatitis is usually photosensitive. What does that mean? It's inflammation of the skin that's worsened by sun exposure. So normally you're going to see these patients, it'll be like their wrists and hands, or their upper arm if they're wearing shorter sleeves, face, neck, sun-exposed areas is where that dermatitis is going to be. And we'll show you some pictures here in a second. It can lead to hallucinations and psychosis there once we get into the dementia phase. And if left untreated, severe cases can cause death. There's the dermatitis, or the cutaneous manifestation of pellagra. Dark, scaly, located on sun-exposed areas. You can see it in this gentleman. Upper chest, face, hands, and wrists. If you're seeing this, obviously we're starting to move more towards, if left untreated, we can start getting into that dementia and ultimately death phase. So this is a pathognomonic sign of deficiency that we need to correct. For toxicity, usually we're going to get vitamin B3 toxicity from medications that we prescribe to our patients, like pharmacotherapy for hyperlipidemia. Normally when you're going to get a toxicity from B3. Cutaneous flushing is the big thing. Nausea, vomiting, elevated liver enzymes if it's too high, but usually it's just cutaneous manifestation. Really not a true toxicity, it's just a sign or symptom that you get. We expect this sometimes when we give our patients niacin to treat their lipids. And interestingly, aspirin helps control that reaction. So a lot of times, if we're giving niacin for someone's lipids, we tell them to take aspirin before they take it. It helps control that flushing. Okay, moving on to B6. These are derivatives of pyridine, and they're listed there for you. They're coenzymes in amino acid metabolism, and making new glucose, and neurotransmitter synthesis. Also, heme synthesis. Because of the heme involvement of B6, peroxidine, it can affect red blood cell formation, deficiency. Most common cause, alcohol again. Also, isoniazid therapy for our TB patients can cause B6 deficiency. Very vague, non-specific signs with B6 deficiency. Once again, glossitis, chiliosis, peripheral neuropathy, muscle weakness. If we have a severe deficiency of B6, we can get a microcytic anemia due to impaired heme synthesis. I would know this sets B6 deficiency apart. Non-specific, if we start to see that microcytic anemia due to impaired heme synthesis, start thinking of your B6 deficiency. The other signs and symptoms, clinical manifestations, can be a couple of the others we already talked about. So toxicity may be peripheral neuropathies and photosensitivity, but it's pretty unusual. Long-term high dose that we take to cause it, greater than 200 mg per day. But this is kind of an anomaly because B6 is water soluble. But you can get some toxicity with really high levels, unlike the rule that we gave that mostly the toxicity is going to be fat soluble. So this is an example of a water-based, a water-soluble vitamin causing toxicity. Vitamin C, ascorbic acid, functions primarily as an antioxidant. Plays a role in collagen synthesis, fatty acid metabolism, neurotransmitter production, prostaglandin metabolism. So because collagen is a major component of all our connective tissues, vitamin C deficiency presents with bleeding and impaired wound healing often. And scurvy. So vitamin C deficiency causes scurvy, historically common among sailors because they didn't get fresh fruits. You get bleeding gums, petechiae. What are petechiae? Anybody? Pinpoint red dots, basically busted little capillaries or venules. Get bleeding gums, petechiae, bruising, usually bruising, poor wound healing, fatigue and weakness. Also, kind of pathognomonic, you can get coiled hair follicles and perifollicular hemorrhage. Right beside the follicles, we'll see it on the next picture, little petechiae all around them. Kind of classic for scurvy. And here's what we just talked about in one little chart for you. And there's some pictures of the inflammation of the gums and the petechiae and the perifollicular hemorrhages. definitely no scurvy or deficiency. Vitamin C toxicity, uncommon, but we can get it with excessive supplements. What can it cause? GI upset, bloating, diarrhea. High doses can give us calcium kidney stones. Something interesting about high vitamin C levels can give us a false negative on a stool occult or fecal occult blood test. If you have too much vitamin C, you can get some calcium oxalate kidney stones, and you'll have a false negative test on your fecal occult blood test. So vitamin D, we talked about it last block, right? So group of sterol compounds, most important calciferol or vitamin D3, critical role in calcium and phosphate homeostasis, which we talked about when we were talking osteoporosis. It promotes intestinal calcium absorption, phosphate absorption, and suppression of the parathyroid hormone. It regulates our bone remodeling. This should be a review. In children, if you have deficiency, it's called rickets. Vitamin C deficiency, it causes a problem with bone mineralization during bone growth. So what do we see in children with vitamin D deficiency? Delayed fontanelle closure. What's fontanelles? Sutures, bone sutures, right? Frontal bossing, that's just going to be evidence of the forehead, right? Evidence of the forehead. It's going to be really pronounced because those fontanelles aren't closing. Widening of the wrists and bowing of the legs. It says on your slide also the rochetic rosary. Y'all seen that on X-ray already? The costochondral junctions. They'll be pronounced, so there'll just be little circles where the ribs join your sternum. You'll see it on the X-ray. Rochetic rosary. Thickening of the costochondral joints. So this is just an illustration of the rickets, bowing of the lower extremities because the bones are soft and we don't have enough vitamin D. We have inadequate mineralization. So we talked about, so in adults, we talked about kids, let's talk about adults. We already talked about it last block, osteomalacia, too little vitamin D. So osteomalacia is after bone growth is already completed in our adult patients. What can we have? Bone pain, muscle weakness, difficulty walking, and we talked about pathological fractures from osteomalacia or osteoporosis. When osteomalacia gets worse, it can become osteoporosis, and we talked about those cutoffs with T-scores. So now we'll talk toxicity for vitamin D. Usually this is from excess supplementation. That's over that 4,000 international units per day. There are symptoms, well, hypercalcemia, taking in too much vitamin D, confusion, polyuria, polydipsia, nausea, and weakness. This is the first time we've discussed polyuria, polydipsia. Those kind of stand out. Confusion, anorexia, vomiting, weakness. We talked about in some other vitamins, toxicity and deficiencies. Okay, that takes us to the end of vitamins. So we're going to move into the next lecture pretty rapidly here. Get started because, like I said, the goal is to get us through these two next short lectures by the end of the day, so we can get a review tomorrow for your test. The check-out learning questions for the 3 lectures we're going to hit today, I'll post this afternoon or this evening. All the rest of them should already be posted there for you on the card, and all the memory jogs are embedded in the slide deck. Let me just change over lectures and we'll move into the next one. Which is pretty straightforward. Appendicitis. All right, so the big thing to know about appendicitis is time matters, and a lot of times we're going to look at this kind of pathognomonic clinical presentation, and we're going to suspect appendicitis if we get certain signs and symptoms in certain time frames. The big issue is making a clinical diagnosis, early recognition, and rapid management. We're going to talk about anatomy a little bit, that classic clinical presentation, and then the physical exams associated with an appendicitis. There's the task. The rest of the large intestine we're going to talk about, anus and rectum today, and then the rest of the large intestine we're going to hit in block 2 when we start talking Crohn's and ulcerative colitis. All right, appendix, also known as the variform appendix, worm-like, worm-shaped appendix, or worm-shaped appendage. Historically, we thought of it as a vestigial organ, right? We don't know that it did anything. It's a vestigial organ that we have that no longer has a function. However, we're finding more and more research is saying that it does maybe play a role in immunity and gut microbe regulation. So we're seeing, our scientists are seeing, there may be more of a function to the appendix than we initially thought. Anatomically, the appendix is a true diverticulum of the cecum. It means it has all of the different layers of the intestinal wall. It's not just a hollow tube at the end hanging off the bottom of our cecum. It actually has all of the layers of the rest of the intestinal wall. So, vermiform appendix, the appendix has a constant anatomical location where it attaches to the cecum. However, the tail can be in a lot of different locations. It can be retrocecal, so behind the cecum. It can be subcecal, under the cecum. And you'll see the entire list there, but a lot of it's related to where it is in location to the cecum or the ileum. And so the next slide kind of shows the different options. And the reason that's important is because depending on where your individual patient's appendix is located, like I said, the base is always going to be on the cecum. But where that tail is can give us some different clinical presentations of where the pain is actually located in our patient that has, for example, a retrocecal appendix or a pre-ileum, which can make diagnosis a little more challenging. There's a picture basically showing all the different anatomical relationships of the appendix in different locations and how it can be closer in front of behind the ileum, the under, side, over the cecum. But seeing the anatomy and seeing how it sits shows us why we can have different presentations of pain. Classically, it's going to start periumbilical for appendicitis, and then it's going to move to right lower quadrant. But depending on where that tail is, it might not move right into the right lower quadrant. It could be right upper quadrant. It could be just off the midline of the umbilicus. So normally classic is periumbilical pain that migrates later to the right lower quadrant. We're going to talk about that in the next slide. So what happens? Why do we have appendicitis? So you get an obstruction of the lumen of the appendix. We saw it was vermiform appendix, like a little worm hanging off at the end of the cecum. It can be obstructed by inflammation or a fecalith, which is basically a hunk or a ball of hardened stool. We can have calculi or stones in the lumen of the appendix. We can have overgrowth of lymph tissue, lymphoid hyperplasia, infections, tumors. Basically, all those listed can obstruct that lumen of the appendix, and then there's this sequence that happens, right? It's obstructed, then it distends, or it widens, opens up. Then bacteria move in, and then we get venous congestion of the fluids and all of the blood in that area, which leads to pressure and ischemia and ultimately death of that appendix. And if we don't treat it or get it out quick enough, we can have perforation and then we're going to have a systemic illness and possibly death. So everywhere where for some reason there's squares should be little arrows. I'm not sure why they didn't change it, but basically obstruction, moving left to right, and follow that down. You're just following the sequence and the pathogenesis of an appendicitis. So the fecalith, hard stony mass of feces, just one of the issues that can cause an obstruction of the appendix. Most common cause is the fecalith of that entire list. Major contributor. The bottom right shows the CT with positive arrow sign with a point down to a fecalith. An image of a CT scan will not be on your channel. Appendicitis, surgical emergency. Because if that appendix becomes necrotic, it can rupture, which is going to lead to bacteria spilling in your abdominal cavity, and you get peritonitis and sepsis, which is life-threatening. Usually, a perf is about 36 hours after the initial symptoms. So if we're waiting to go to the ER, or you can't get to the ER about 36 hours after this pain starts, and it's following that sequence we just discussed, the pathogenesis of appendicitis, you can have a life-threatening perforation around 36 hours. So that makes it imperative that we get an early diagnosis and surgical consult. Classic presentation, already told you, vague periumbilical pain around the belly button, and that's due to the inflammation stimulating visceral afferent fibers. So it's poorly localized pain fibers. Then as inflammation progresses, we get into the parietal peritoneum, and that's when it shoots down to that right lower quadrant. Usually around 12 hours. After you start getting the periumbilical pain, your patient then, after 12 hours or so, that pain is going to start migrating down into the right lower quadrant, if they have a normal anatomical appendix. So there's a classic spot called McBurney's Point, and we heard of it before. It's a specific area in the right lower quadrant where we're saying that if your pinpoint tenderness there, that's usually indicative of of appendicitis. Basically, a 1/3 of the distance between the belly button and the anterior superior iliac spine. Highly suggestive of appendicitis. Your patients are always also going to complain that if they're riding in a bumpy car, it's aggravating their pain. If they have any kind of movement, like coughing, it's going to worsen their pain. Pain is usually sharp and worsened by any type of movement. Better by lying still. And this is just a graphic showing it starts periumbilical and then moves to the right lower quadrant. So the position of the appendix, as I mentioned, can change the clinical presentation from that classic one. For example, retrocecal appendix may produce right flank pain versus that right lower quadrant pain. And what the graphic is showing you there is the pregnant patient, how the uterus will displace the appendix based on where she is in gestational age. It will displace that appendix higher and higher and higher in the abdominal cavity the further along in pregnancy the patient may be. So now, instead of the periumbilical pain then shooting to the right quadrant, it can be to the right lower quadrant. Now, as the appendix is moving up based on where she's at in her pregnancy, it can cause either right upper quadrant or even up subcostal, because according to where she is in pregnancy, that end of the appendix can be displaced by the uterus as it grows. So with the appendicitis, not only the pain, but usually nausea, vomiting, anorexia, they don't want to eat. That's an important sign. If the patient still wants to eat, they still have an appetite, it's probably not an appendix. Low-grade fever usually. Anorexia very common in appendicitis. low grade if it's uncomplicated appendicitis. However, if we start getting high grade fevers, 103 Fahrenheit and above, if your patient starts having rigors and signs of a hot belly, then we're moving towards a perforation or advanced infection. Get into surgery quickly. McBurney's point, we talked about it, where it was. So we have tenderness there. Also, direct and rebound tenderness. We remember what rebound tenderness is. Push in the left lower quadrant hurts on the right lower quadrant, or vice versa. Guarding abdominal rigidity. So now we're looking at these signs and symptoms are now the peritoneum getting irritated. So we're getting further along into our appendicitis pathogenesis. So do we remember the exams specific to appendix? Rothsing's, SOAS, and obturator? We remember those from last semester or this semester? So Rothsing, palpate in the left lower quadrant, hurts over in the right. Signs basically the pain roving around, right? I'm pushing on the left, it hurts on the right. SOAS, so extending the hip, because the peritoneum is starting to get inflamed, so extending the hip can give us belly pain. And then obturator, when we internally rotate that flexed hip, you get pain. That's a flamed appendix that's irritating the muscles in the area. So, and then the heel tap. Hitting on the end of the heel is causing movement, and as I said, your patient's going to say their pain is worse with any movement. There's McBurney's point, and then I guess that's a picture of, I don't remember the gentleman's first name. The name came from a Dr. McBurney, like turn of the 1800s to 1900s, so mid to late 1800s, early 1900s. Not that it matters. All right, here's a good time for a break. Let's take 10. We'll finish up appendicitis, and we'll talk very briefly about hemorrhoids and fissures. Finish up the block.
There's somebody here.
Right, those are all types of and if it's missing anything,
Good, you're start looking like 38. No, I think I don't know.
don't know if like he just it's gonna get over nice. So I don't know if he said bring it to school. He didn't think it was make it. I know he's gonna try to bring it here. He's gonna try to get the parents to bring it here to San bad check. I saw that, remember that airborne thing? Get ready, dude. R.I.P. have fun. Way too into the house, dude. Going down.
In the toxic area, the kids playing with dogs. I don't know why I'm like, it was toxic area. That's when I was like, bookworm also has dog tapeworm or something like that. Yeah, I was thinking because they were playing with dogs, so they probably got dog tapeworm. I changed it last night.
Was in the toxic area. The vignette reading it, it's like, alright, this has to be like one of those like
I was thinking it.
But then I saw the very last portion of the question was like the eye. It's like, that's interesting. You know, the only one that I remember was the toxic area.
Yeah.
So I'm like, so I don't remember how to get. I just remember the eye.
I do not remember the eye. I saw
There's a picture of it.
yeah, the
Yeah.
crazy white.
I just remember that. Because initially I put hotel. But then it's like, alright, what's the definition? No, like,
Here we close March 12th. Side tomorrow. With that at.
you need a
GASTRO side option.
well, you can make your money work here. This
Yeah. This parking lot's been closed. We park over here. So you see that's where we have to walk up that way. So it's that road before it's off.
from last year.
And then some of the ones I noticed I made mistakes because of the hype. Yeah, so I'm not gonna
See, Neuro, the longest we did that. Was that great?
So you might do it with your, yes, you do it with your small protein. It depends
Does he give you a chance to like, you guys are teachers, like, turn in or something? So like,
Oh, strong, we can't lose this one.
That's what ours said too.
Like,
The problem is that the it's for 2 weeks.
Well, it's not due yet, so who's there?
I gotta know, like what I did okay and what I need to just check it and call that a rated one. I don't care.
He's also been on leave.
No, like the presentation.
Presentation is pretty much like reading, but you have to follow this.
Yeah.
We did all of us said the same teacher. They're saying, you see that
Actually, I had this, you went through the trailing. You gotta get the names. Oh yeah. So regular, dude, they have a sniper thing that train us that you do. They'll like just buy you ammo. Call
Every time.
Are you ready to go ahead and start back? So finishing up with appendicitis, we talked about how we get them, what it looks like, what the patient looks like, so now we're going to talk about the workup when you suspect an appendicitis. Pretty basic CBC, what we see, probably a leukocytosis, high white count. You want to get a CMP and then a UA. You want to make sure there's no urinary cause of what the patient's presenting with. Modality of choice in an adult is CT scan with contrast. Important to know though that you don't delay surgical care if you can't get into a scanner. So the CT in adult, CT with contrast, excellent sensitivity, excellent specificity for the appendicitis, but don't delay surgical care if imaging is not available. So even though you don't have the imaging, you highly suspect it, go ahead and get your surgical consultant. Pregnant patients and children, usually we look at an ultrasound for that population, just to decrease the amount of radiation exposure. So classification, either uncomplicated or complicated. Uncomplicated appendicitis, localized inflammation, no perforation. However, complicated, now we're going to have perforations, possible abscess, phlegmon. Who knows what a phlegmon is? Basically, it's an abscess, but there's no wall. It's not walled off, it just expands. It's expanding, spreading, non-circumscribed area of inflammation in soft tissue. If you have a temp greater than 103, complicated. White count above 15,000, complicated category. If we have fluid in the right lower quadrant, complicated when we do our CT. So what does that mean? We got to know that our patient's high risk for complications. So know the two different category classifications. Pretty straightforward. So complications can include gangrene, which is necrosis of the wall of the appendix. Perforation is basically it ruptures, the appendix ruptures. Phlegmon, like I mentioned, inflammatory mass without clear defined walls. And abscess, same as a phlegmon, but you have clearly defined walls. It's walled off in a confined space. Whereas the phlegmon, it's allowed to spread into surrounding soft tissue because it's not walled off. Treatment, surgery. Surgical appendectomy, most crucial part of the patient's care. Risk of perf after 24 hours, significantly increased. time-sensitive surgical emergency if it's been more than 12, 24 hours of these, the patient having these signs and symptoms. So it's a time-sensitive surgical emergency. As I said, definitive treatment, surgery, take out the appendix. Get an early surgical consult. And in the ER, probably going to go ahead and start some antibiotics, some broad spectrum antibiotics. And they're listed there on the bottom of the slide. And this is just showing the laparoscopic approach. Basically, just removing that little vestigial, possibly vestigial worm-like appendage from the secret. All right, so we're going to move now into the last topic for block 1. So we'll just bring up that slide. And the last topic for this block is going to be anorectal disease. So, main conditions we're going to discuss: hemorrhoids, anal fissures, anorectal infections, and anal carcinoma very briefly. There's your learning objective and tasks. You can look at those on the card if you so desire. So as I said, we'll talk hemorrhoids, anal fissures, anorectal infections, and a little about anal carcinoma. They present often similarly, right? So we got to be able to pick out what differentiates or what helps us zoom in on one diagnosis versus the other. Most of them are going to have rectal bleeding. Most of them are going to have pain. So we have to clinically distinguish what's going on with our patient. First is hemorrhoids. Basically, what are hemorrhoids? They're the normal vascular structures that are in our anal canal. It's the vessels, basically they're like little cushions. But they maintain our anal continence and they provide a watertight seal of the anal canal. So they're normal, but hemorrhoids become symptomatic when there's increased pressure and those venous structures get dilated or inflamed, usually from increased pressure. So you do need to know the dentate line, what it is, start there for you, important anatomical concept because this will drive your diagnosis. If it's above or below the dentate line, if the issue is above or below it. So what is the dentate line? It separates areas of different nerve innervation and the type of epithelium that's in the anal canal. Anatomically, it's going to separate columnar epithelium of the rectum from the squamous epithelium of the anal canal, which means it has a different type of nerve supply. So hemorrhoids are going to be either classified as internal or external, and some of the other disease processes are internal and external, depending on it's above or below that dentate line. The ones above it, because of the way nerve tissue innervates above the dentate line, usually painless. That's where your internal hemorrhoids are. If it's an issue below the dentate line, different type of nerve innervation, different type of epithelium, and so there, below the dentate line, usually we do have pain. Just another diagram here, now adding in the external hemorrhoids and the internal hemorrhoids. Like I said, dilation of those normal venous complexes, usually due to increased pressure. So above the dentate line, internal hemorrhoids, proximal to the dentate line. And they come from the superior hemorrhoidal veins. Usually painless, because it has visceral innervation above the dentate line. Whereas external, below, or distal to the dentate line, usually you're going to have pain there, because squamous epithelium covers those vessels. So now we have a somatic innervation, so lots of pain. We have external hemorrhoids. Usually, as I mentioned, pressure increases, makes our veins swell or dilate, and that's when we start to have an issue with hemorrhoids. Common, it causes strain during bowel movements, i.e. increased pressure. Chronic constipation, prolonged sitting can lead to increased pressure on those venous cushions. Pregnancy increases fluids and pressures. Obesity and low fiber diet. There's all your causes of hemorrhoids. Because they all increase pressure on those venous plexuses of your lower anus and rectum, which can lead to issues. Most common symptom of hemorrhoids, painless, bright red bleeding. Small amounts, though. Small amounts. Not like some of the other conditions we discussed last week. So these patients will see bright red blood on the toilet paper, streaks on their stool, or little bits of blood, drops of blood dripping into the toilet. Other symptoms, they complain of itching or pruritus, mucus discharge, or irritation. If they say pain, it's usually external hemorrhoid. Important concept for hemorrhoidal disease process. External equals pain. Internal hemorrhoids can produce a lot of mucus secretion, so it can irritate that perianal skin. And then prolapsed internal hemorrhoids may cause leakage of rectal contents. So skin irritation and pruritus if that happens. External hemorrhoids can actually cause skin tags. So then we can have some difficulty with patient hygiene if you start developing the skin tags from external hemorrhoids. And then poor hygiene conditions lead to chronic perianal irritation and discomfort. Physical exam, most important part, we start differentiating between internal and external hemorrhoids or other conditions. So external hemorrhoids and prolapsed internal hemorrhoids meaning they've prolapsed now outside the anal sphincter, so you can see those. They're visible on inspection. However, if it's an internal hemorrhoid that's not prolapsed outside the rectal canal, then we might not be able to see them with visual inspection unless the patient valsalvas. Then we may see that prolapsed internal, or if we use an anoscope and actually look. So maybe if they're prolapsed, we'll see an internal. We'll definitely see an external just with visual exam. But if we need to use an anoscope or have them valsalva, we may see the internal hemorrhoids. Also, for these patients, you want to do a digital rectal exam. If they have rectal bleeding, do a digital rectal exam. And the anoscope, if you can identify external hemorrhoids or prolapsed internal hemorrhoids visually, which I showed you a picture of a couple of lectures ago, just basically a little scope, a little speculum you put in, dilate with a light, and then you can see that intake line, and you can see if there's any internal hemorrhoids there. You need to know the classifications of internals, i.e. the grades, the difference between the grades. Because it's important to discuss the grades when you have a patient with internal hemorrhoids, because that changes treatment. It matters whether they're bleeding and they're not prolapsed, or whether they're prolapsed and they reduce on their own back up into the anal canal, or if you can digitally or manually reduce them back into the anal canal, or if they're incarcerated and they cannot be manually reduced. So know the classifications by grade and what that means. It helps us determine if we're going to treat these internal hemorrhoids conservatively, or are we going to move to a procedure. This is the same thought process. Now we're just looking at a different slice, a transverse slice here, a sagittal slice, showing the internal hemorrhoids and the grading based on where they are in the canal. And if they return by themselves, if they return manually, or if they stay down, they cannot be reduced. So thrombosed hemorrhoids, we can get thrombosis of the hemorrhoids, both internal and external. Usually external, but we can get internal thrombosis as well. It's acute and it's severe. Usually it looks like a little bluish mass right by the anus. And actually, I think we have a slide picture coming up next of a thrombosed hemorrhoid. These require surgical evacuation of the clot. The reason they're a bluish mass is because they actually have a thrombosis in them, so a blood clot, and we have to excise that clot. Acutely painful for the patient, and then we excise it, and they get a lot of symptomatic relief. There's the picture of the external thrombosed hemorrhoid, which requires a hemorrhectomy. Put some lidocaine in it, you make an elliptical incision, and then you remove it, and then you often put some packing in, and you have them taking sitz baths. So just a couple of inches of warm water, sitting down in it to relax the tissues. Also give them some stool softener so it's easier to pass stool, and then something for the pain. Like I said, they're exquisitely painful. And then a donut to sit on to keep the pressure off of the area. Usually we manage hemorrhoids conservatively. What's that mean? Increase fiber, increase fluid intake, i.e. making the stools easier to be passed, like we discussed with our chronic constipation patients. We give them some good bowel habits. If you have to go and strain, don't strain, try to avoid it. Get increased fluid, increased fiber. Go only when you have to go. Limit the amount of times you're sitting on the toilet for an extended period of time, because that just continues to build pressure, which can worsen the hemorrhoids. Have them exercise and talk to them about weight loss and decreased pressure on that venous plexus. Usually manage hemorrhoids conservatively. And these lifestyle changes here, general treatment measures, that's our foundation. Start there for all patients, internal or external. We can give some topical medications if our patient's having symptoms, witch hazel pads, those Tux pads. Most of these are OTC, and you'll have them in your sets and kits. The topical hydrocortisone, proctofoam, either cream or foam. Topical anesthetics, once again, either fluoxetine or lidocaine. Also, we can do vasoconstrictors like phenylphrine, name brand, preparation H. And then we can do hydrocortisone suppositories. Everything aimed at numbing the area or shrinking or getting rid of the pressure in the veins. For internal, we have some other options. If the first lifestyle changes and those first line topical medications or attempts to shrink it with steroids or numb the pain, that's not working, patient's still symptomatic. For internal hemorrhoids, we can do rubber band ligation, sclerotherapy, so they're injecting some sodium chloride, right, to kind of scar it up and decrease the inflammation in that venous plexus, or electrocoagulation. Surgical hemorrhoidectomy, reserved for severe refractory cases. Severe. So very chronic, severe bleeding, because there's a high risk with the surgical procedures for hemorrhoids to get fecal incontinence. And it's a very painful surgery and recovery. Everything has to fail before you do surgery. It's an important concept to know that there's some other things that can be done after lifestyle changes and some generally over-the-counter things. We can do a rubber band ligation for internal. We can do sclerotherapy or electrocoagulation before we move to surgery. Last option, surgery, because of the risk I mentioned. Moving on now to anal fissures. These are not hemorrhoids. It's a tear in the anoderm, distal to the dentate line. So more in line with external hemorrhoids, and they're distal to the dentate line. So is an anal fissure going to be painful or non-painful? exquisitely painful. Exquisitely painful. It has somatic intervention below the dentate line, so they cause severe pain, especially during bowel movements, which is a problem because patients will try to hold it and not go because it's so painful when they actually do defecate. Usually, it's the fissures are caused by trauma during defecation, i.e., long-standing constipation, or a patient straining, or a very high internal sphincter tone. You can have fissures from trauma, such as anal intercourse or foreign body insertion. Fissures can be acute or chronic. Chronic are usually there because you have some spasm of the internal sphincter. So the fissure has impaired healing because of that spasm. Most anal fissures, 90% of them are posterior midline. 10% of them anterior midline. So you need to know the causes on the left that are off midline. We're going to talk about them more in depth when we get into the large bowel discussion on Friday after the test. But know the anal fissures cause that are off midline: Crohn's, HIV, tuberculosis, syphilis, carcinoma, trauma. Because if you see them over there where less than 1% of anal fissures happen, you need to be thinking about these things. Clinical presentation, it hurts when they defecate severely. Severe tearing pain with defecation. Sometimes some mild right rib bleeding, not quite as much as with a hemorrhoid. They don't bleed as much. But your patient will say, I don't want to defecate. I don't want to go to the bathroom. It hurts too bad. So they have a fear of bowel movements because of the pain. So they intentionally avoid it, which can worsen their constipation, which then when they do go, guess what happens? It worsens their anal fissure. Because now they're straining and passing harder stools because they didn't defecate when they had to go. Examination reveals a tear, usually external, and then basically you have the patient, you tell them you want to do the examination, and they're going to say, no, it hurts too bad, we are not doing an endoscope, we are not going to spread the buttocks because it hurts too bad. You go in and do an exam and they're screaming a lot of times with anal fissure patients. So you can't really get a DRE. If you can, great, but usually the patient is not going to allow you to. It's not tolerable. And you may also see a sentinel pile. That's a skin tag on the edge of the fissure. Just like you can get skin tags from your chronic external hemorrhoids. There's a picture of the anal fissure. It's a small tear, but you can see not bleeding. And you can understand why the bowel movements, severe pain. How do we treat it? Sitz baths. Once again, that's just sitting in warm water 2 to 3 inches deep. We can give our patient a sitz bath, which is basically a little plastic bowl that sits on the toilet. Fill it with this much water, have them sitting on it 10 or 20 minutes just to relax the area. Sometimes we do put some Epsom salts or other things in it, but it can't just be warm water. Stool softener is imperative for these patients. Once again, just like hemorrhoids, kind of the same causes, so the same treatment. Lifestyle changes, increase that fiber and fluid. We can give them some topical anesthetics again to help relieve the pain. We can use topical vasodilators like nitroglycerin, dialtazam, and afidipine. What does that do? As I mentioned, if the internal sphincter is tight, then if we can relax that internal sphincter, it can help with healing. If it stays, if the sphincter tone stays tight or increased, a lot of times that's delayed healing. So often we'll refer to those topical vasodilators as a chemical sphincterectomy. Afidipine, dialtazam, and nitroglycerin, so topicals. Also, we could use botulism toxin to relax that sphincter. That's becoming more popular. But that's a chemical sphincterectomy, so we're not operating, but we're using topical medications to kind of relieve and give them symptom relief, but also promote healing. By using anti-inflammation and muscle relaxation of that tone, if we use the botulism, and then vasodilation with some of the topicals such as the nitro and the dialkazam. If after 4 weeks or so it's still bothering them, we can move to surgical options. There's a surgical option to close the lateral internal sphincterectomy, fissurectomy, and botulism toxin again can be used possible to heal when you cause paralysis in that area with botulism injection. But you give them 4 weeks of the lifestyle changes and then move into the topical vasodilator area, which is another 4 weeks. And if that doesn't work, we can talk about the chronic fissure surgical treatment listed there. So 4 weeks of lifestyle, 4 weeks of then the chemical sphincterectomy. If that doesn't work, a week 8 or so, we can refer them out to that surgical consult. So now we're moving into anal rectal infections, different from an abscess. Different from a hemorrhoid, different from a fissure. This is an infection in the anal crypts or anal glands. So basically, you get a collection of pure material coming from those crypts in the anus or the rectum. And you should all be familiar with what an abscess is. So you got inflammation, you got fluctuance, erythema, all displayed in the picture. So the anal glands and the anal crypt, what they do, basically lubricate the anal canal, help to pass stools. So if you get an infection in that area, it can kind of build up in the area and then start to kind of fester and show its way out to the external tissue surrounding the anus, which we just saw a picture of. So it's an anal rectal abscess. We can categorize them into perianal versus perirectal according to where they're located during your exam. This picture shows that slice of showing where the difference is of those different abscesses forming either in the perianal or perirectal area, and if they're simple versus complex. Usually, severe constant anorectal pain. You can imagine after looking at the picture how your patient's going to feel if they have an anorectal abscess. Severe constant pain, often fever and malaise, and your patient will, if it's draining, your patient's going to complain of a foul smelling drainage. So foul smelling drainage from the abscess, and it's spontaneous. The important difference between this and the hemorrhoids and the fissure, usually you're not going to have much of a change in the pain or how it's presenting with an abscess when you defecate versus with hemorrhoids and the fissure we talked about, increasing pain. So physical exam, you saw it in the picture, it's swollen, erythematous, edematous, fluctuant skin. Looks like an abscess, right? With surrounding induration. You need to do the digital rectal because some are not going to present, your patient's not going to always present with that visible abscess. It may not be visible on external exam, so you need to do the DRE and see if you're identifying an abscess internally. Because they're often not really apparent. But if you do the DRE and you can identify it through an area of pain or feel the fluctuance, or use your anoscope to see if you can visualize it internally. If it's complicated, severe, we might have to do a CT to see if there's tracts or fistulas between the abscesses. Treatment, simple. What do? We IND it, right? Incise it, drain it, and pack it, and then sits fast again, just to decrease inflammation in the area. If it's complex, they're probably going to get admitted, especially if there's any fistulas, which we're gonna talk about here in just a second. But they may need surgical drainage for a complex abscess. A fistula, now we have a tract. So you get an abscess, and then you're gonna have a tract, basically an epithelialized tract that can connect the anorectal canal to the external skin. This is often you'll see in your patients with Crohn's disease. Periancral abscesses, and then you'll have spontaneous drainage from them, and they become chronic, and then we'll get a tract between the anorectal canal out to the skin. Fistula. And that's exactly what I just discussed. Chronic purulent drainage, pruritus, so itching, pain, and this is surgical excision. Patient's going to say chronic purulent drainage, pain, and itching. And you identify it on exam, and then you send them out for surgical excision of the fistula. Next, we're talking infections. So not an abscess, but infectious proctitis. Usually you're going to see infectious proctitis is going to be an STD, sexually transmitted. The big players there on the slide, gonorrhea, syphilis, chlamydia, and herpes. How do they present? Anorectal discomfort, tenesmus, so spasm of the sphincter, often constipation, and either mucus or bloody discharge. And then for each of those common STD causes on the next slide, we're going to talk about kind of what's pathognomonic for each one. So infectious proctitis. Syphilis will give you a chancre. Herpes is group vesicles, which I think this should all be a review. I'm not going to ask you specifically which STD is causing infectious proctitis. Just know the ones that can. Gonorrhea is mucopurulent discharge, and chlamydia is a slight discharge, and it may be asymptomatic for chlamydia cause of that infected proctitis. And then what do you do? Lab testing for the suspected pathogen of origin. Condyloma acuminata, anal warts, usually from HPV. They itch, they bleed, and they're painful. They may coalesce, so they group, as they're presenting, they start to group together and overlap, and they can actually obscure the anal opening. The next slide is a picture. Usually that's going to happen when you have an immunocompromised patient. You have to distinguish the condyloma acuminata, the anal warts, from cancer. They can present similarly, and there's a picture of those coalescing acumulata, those anal warts. So the last topic, carcinoma of the anus, is very rare, but most cases are squamous cell cancers associated with HPV. Risk factors for anal carcinoma: anal warts, which we just saw and discussed, saw the picture, immunosuppression, and anoreceptive intercourse. So those are all high risk for carcinoma of the anus, anal carcinoma. Usually squamous cell cancers, but it's pretty rare, unless you have one of these risk factors I just mentioned. How do they present? A lot of times we are going to confuse these anorectal cancers with hemorrhoids because they have rectal bleeding, pain, but they'll often have a palpable mass. A lot of times anorectal cancer is misdiagnosed early as hemorrhoids. We're going to need to get a CT and an MRI to see if we can find tumors and if we have any signs of mets or metastasis elsewhere in the body out of the anus. So that finishes up all of the topics and lectures for Block 1. I will post the check on learning questions for the 3 kind of brief topics we hit today.